I am Dr. Camille Gailly, and I'm going to talk on pancreatic neuroendocrine tumor, namely insulinoma. The main objective actually of this presentation is to create awareness to patients on pancreatic neuroendocrine tumor, namely insulinoma. For this presentation, I declared no conflict of interest. So, before starting on neuroendocrine tumor of the pancreas, it is very important actually to appreciate the anatomy of the pancreas. The pancreas actually is divided into three main parts: the body of the pancreas, the head of the pancreas, and the tail of the pancreas. We have different pancreatic islet cells in the pancreas, namely alpha cell, beta cell, delta cell, and for our presentation, I'm going to concentrate on beta cell which secrete insulin. So in pancreatic neuroendocrine tumor, namely insulinoma, there is a hypersecretion of the beta cell where there is increased secretion in insulin and proinsulin. It is very important to realize that pancreatic neuroendocrine tumor can be at any place. It can be at the head, the body, or the tail, and it can be in different numbers. So what is a neuroendocrine tumor? It is actually a malignant growth arising from neuroendocrine cell. It can occur in the GI tract, in the lungs, in the pancreas. Example of GI tract neuroendocrine tumor are gastrinoma, 30% cases, insulinoma, glucagonoma, and we have also vipoma, which are very rare. It is very important to differentiate between a functioning tumor and a non-functioning tumor. In a functioning tumor, there is a hypersecretion of the hormone. Example, insulinoma, there is a hypersecretion of the islet beta cell and increase in secretion in insulin. Now, insulinoma is a functioning neuroendocrine tumor. It is actually the most common functioning endocrine neoplasm of the pancreas. There is secretion of insulin and proinsulin, and in 90% cases it is a benign lesion. In 90% cases it is solitary, and in 90% cases it is in the intrahepatic. Most of the cases, 90% cases, are less than 2 centimeters of diameter. So an easy way to remember is a rule of 90%. So in 90% cases it is benign, solitary, intrahepatic, and less than 2 centimeters in diameter. Now, once we have a suspicion of insulinoma, we have a workup that we have to follow. The first thing, when do we suspect insulinoma? We suspect insulinoma when patients present themselves with hypoglycemia, essentially fasting hypoglycemia and hypoglycemia after strenuous exercise. So what are the signs and symptoms of hypoglycemia? The patient will come to us with lethargy, weakness, blurring of vision, confusion. It can go up to a coma. So this is what we call a hypoglycemia. When we check the blood glucose of this patient, it will be less than 50 mg per deciliter. And when we give glucose to this patient, there is a resolution of symptoms. This is what we refer as a Whipple triad. So when we have cases of hypoglycemia in our daily practice, it is also very important to realize that that insulinoma is not very common. We have many differential diagnoses that we have to consider. And one of the main differential diagnoses are drugs. Drugs, namely insulin, secretagogue, drugs like indomethacin, or another common feature, especially on weekends, are alcoholic intoxication, where we have patients admitted with hypoglycemia due to binge drinking. Other endocrinopathy which can give hypoglycemia are Addison disease or hypopituitarism, and we have rare cases like autoimmune cases like insulin receptor antibodies, autoimmune disease. We also have hypoglycemia in our critical care setup, where we have patients with multi-organ dysfunction, liver failure, renal failure, end-stage renal failure, and hemodialysis, sepsis, extensive burn. These are cases that we see frequently in our critical care setup where hypoglycemia is due to these causes. The tests that allow us to confirm the presence of an insulinoma, the biochemical confirmation is the gold standard is a 72-hour fasting test, which can detect up to 95% of insulinoma. So what we do a 72-hour fasting of patient, and where we check the insulin level, we check the C-peptide, and we check the absence of any metabolite like sulfonylurea in the blood or the urine. So the consensus diagnosis is to have an insulin level about 10 microunit per ml, C-peptide exceeding 2.5 nanogram per ml, and an increase of proinsulin above 20 picomole per liter. Now that we have confirmed the presence of insulinoma, we have to localize it. It's very important to localize it because what we're going to see later, surgery is important to have a good localization of the insulinoma. So what we have as radiological investigation, we have contrast CT scan of the abdomen, we can use MRI, or we can even use echoendoscopy detection. It is very important to realize that the echoendoscopy detection is an invasive method. However, it has a detection rate of 92%. As you can appreciate on this diagram, we have a CT scan contrast of the abdomen, where we can see that we have a hyperdense lesion in the head of the pancreas, essentially reflecting an insulinoma. On your right side, you will see an insulinoma on echoendoscopy. Now that we have localized the insulinoma, it is important to talk on treatment. When we treat a patient with insulinoma, it should be done by a multidisciplinary team consisting of physician, endocrinologist, surgeon, pancreatic surgeon. It's very important to have a team which is at ease with treating these cases and, if possible, in tertiary healthcare. Now, the treatment will depend where the insulinoma is, the presence of one or more tumors, and whether the tumor has spread to other parts of the body, and also on the general conditions of the patient. So, surgery is a curative option. So, if we have to do the tumor which is less than 2 centimeters in diameter and localized tumor, we can opt for tumor enucleation, which can be done laparoscopically when we remove the tumor itself. Now, if you're having to do with tumors of the body or the tail of the pancreas, or a tumor which is near the pancreatic duct, this is going to be an open surgery where when we remove the body and tail of the pancreas, we refer to as a distal pancreatectomy. If we are having to do with tumors at the head of the pancreas, we can go for a pylorus preserving pancreaticoduodenectomy. Or we also have the Whipple operation where we remove the pancreas whole. We also have other technique which is used when surgery is not feasible. For example, in patients where we have a fragile who cannot sustain a major surgery, we can go for radiofrequency ablation, or we can go for transanterior embolization for liver metastasis. We also have the contribution of drugs in the management of insulinoma. We do have drugs which can decrease the amount of insulin produced. Example is dioxide. In cases of metastatic insulinoma, we can go for chemotherapy. And in cases we have insulinoma who has got receptors for somatostatin, we can go for somatostatin analogs, octreotide or lanreotide. So just to summarize the management, so if we are having to do with a patient with an insulinoma which is localized, the option and which is fit for surgery, the option is to go for a enucleation or a partial pancreatectomy. In patients who are fragile, who will not be able to go for a general anesthesia, we go for radiofrequency ablation, we go for alcohol ablation, we go for embolization. In cases of malignant insulinoma, which is not resecable, we have to go for radiofrequency ablation or for intra-arterial chemotherapy for liver metastasis. And in case it is resecable, we had to go for an aggressive surgical resection where we had to remove the regional lymph nodes. Thank you very much for your attention.